Thank you, sir, and AIOS for this opportunity. With the last comment by Dr. Mahesh, sir, it makes my talk very easy. He said in CSR, in elderly, we need to treat early. I'll just skip the initial part because it's already been covered by the previous speakers. Uh, Mainly, I'll be focusing on octa changes in CSCR, and I'll be then shifting over two cases, two interesting cases, one of which has partly been discussed by Girdhar sir. The octa changes which have been discussed in CSCR, they have been described as hypoperfusion, flow voids, and detection of the ambiguous um, macular neovascularization in cases where you have SIR or the DLS. So the first case, I'll directly jump into that case. It's a 68-year-old gentleman who presented with scotoma in the left eye for a duration of few months. And since he was working abroad, he was unable to come up for regular follow-ups. But since he was there, that time he just did an OCT on this, which shows a serous macular detachment and an irregular RPE. And mind you, just note here that it is 2014. This is prior to the era when octa was in use in the clinical practice, or even it has not even seen the light of the day. So that time we observed, and to the patient's benefit, 2 months down the line, the patient's vision improved. OCT also showed a good resolution of serous macular detachment, and the patient kept on coming back for follow-ups as and when required. But then this time again there was a fluctuation of the scotoma pattern with a drop in the vision. Patient was advised investigations further, but the patient wanted to have go at observation, which was good for the patient. Again, 2 months down the line, the patient again improved spontaneously. Then somehow the patient was lost to follow-up for a period of 4 years, and after which he only underwent cataract surgeries in both the eyes. And mind you, from 2014 till 2019, the patient has never undergone any treatment for CSCR as such. Then COVID hit in, the patient was lost again to follow up, and only presented in April of 2022 with defect in vision in the left eye. So at that time, when we did the OCT, you can see three different sections from the part of the lesion. In the upper part, you can see a serous macular detachment, hyperfluorescent dots. You can see hyperreflective dots. You can see peaked PED, intraretinal fluid, and a serous macular detachment. The patient also underwent ICG, and it showed up a very beautiful subfoveal polyp. So the patient was given an a chance of brolucizumab, one dose, and following the injection, this is what happened to the lesion. The DLS almost flattened, the PED reduced in size significantly, and the serous PED completely collapsed. The patient also underwent an ICG following the injection, and following the injection, you can see with one injection itself, the polyp had totally disappeared. The patient was, due to the waxing waning nature of the disease and inability of patient to come for a follow-up, one more injection of brolucizumab was given, and the patient at his 3-month follow-up following the second injection had shown a significant improvement in all of the lesions which have been described. In this patient, over a period of 7 years, you can see the progression of the disease in an autofluorescence from the initial left upper part of the screen, almost a minimal area of hyperautofluorescence below the area of the fovea, to an increased area of hyperautofluorescence which is seen in the perifoveal location in the last follow-up an year back. Although this patient also underwent octa, but this octa was quite late in the course of the disease because it was not available prior to it. And at this point of time, it was before the injection. This is after the second injection, and this is following the second injection at the third follow-up, where there was a slight reduction in the network. Now coming to the second case, which was also highlighted by Dr. Girdhar sir. This is the same patient. It is a doctor, elderly doctor. And I've just put in the slide just for you to appreciate the fact that the patient's vision has never fluctuated beyond a certain limit. It's always been in the range of 6/9, N8, N6, that range. The patient only came with the presence of scotoma. That is the only complaint which the patient had. The initial presentation, there was a slight dip in vision that was around 6/15 N12. You can see a serous detachment temporal to the fovea. Left eye shows an ERM with a vascular distortion in the inferior arcade. When we did the OCT, at that point of time, there was only serous macular detachment with an irregular RPE. some hyperreflective dots in the outer retinal layers. And we observed the patient, and the patient was told about the need for FFA in the second visit. The fluid automatically reduced in the next visit. FFA did only show just a mild window defect in the later phases of the angiogram. Since there was no leak, the patient was only observed. The patient again came in with a scotoma. We asked him again to undergo ICG and OCT because this was recurring, and since he was beyond the certain the age for the typical CSR, so that time the patient again refused. He wanted to wait for it, but then the symptoms did not abate. The patient had to come back to us 2-3 months down the line when he underwent ICG. When we did the ICG, there was no polyp in the earlier phases of the angiogram. However, the later phases only showed something like a staining in the later phase in the inferotemporal part of the fovea. Left eye was normal. And this is how the OCT looked. Now, from a serous macular detachment, it has come to something like what is known as STREM and an irregular RP along with it. The OCTA also did not reveal any pattern of frank network-like lesion, but still, due to the waxing waning nature of the disease and keeping in mind the patient's age, the patient was given a dose of, he was treated with a half-dose PDT, and this is the pre-PDT OCT, and this is how the patient looked 1 month following the PDT. On recent follow-up, on a follow-up 6 months down the line, the patient maintained a dry fovea, and he was asked to follow up every 3 to 4 monthly, but then he only presented after COVID abated, and he came in with a mild scotoma again. Now, at every point in time, his vision remains in more or less the same way. So at this time, we took the patient up for an OCTA. He has a frank DLS sign here with a serous macular detachment. And here the OCTA shows, I've not put in that other scan, but in the areas of just below the DLS, we could see flow signals which correspond to 2 areas of the network which are seen in the lower part of the slide. So the patient was given an anti-VEGF. Following the anti-VEGF, the fluid on OCT has gone, but the network keeps on changing its pattern and it is still persistent. So the network persisted, and so did we with the treatment part of it, and we kept on injecting till the network significantly went away. The patient actually landed up having somewhere around 8 to 10 injections, and in due course of time, the morphology of the network on OCTA also changed something into like a Medusa head appearance, as you see here. So this is in nutshell the case as seen on an OCT. In none of the follow-ups you see anything more than a serous macular detachment, irregular RPE, or probably a DLS evolving. However, the OCTA does show you different stages of a network which is responding to treatment, modifying, and then finally settling at a certain level. So with this, I'll just like to end my talk that CSCR in the elderly population tends to pose a significant challenge towards diagnosis and management. Multimodal imaging is crucial to diagnosis. OCTA definitely plays a significant role, and close observation with a high index of suspicion is often needed to manage a case appropriately. Thank you.
Any questions? We can have some questions. Any comments? I think there are some people, persons who would like. Any comments? Any questions? Yeah.
Thank you, Dr. Giri. I just wanted to know the brolucizumab that you used in your case. It shows that the ellipsoid zone gets disrupted, something that we had also seen in some patients in AMD. So, is it something that you're seeing commonly? And my second question or comment is
brolucizumab in particular, or in this case?
In that case that you showed.
In this case, it didn't affect much. The vision improved actually, and the patient stabilized following the injection.
Okay, and how closely do you follow these OCTA-related CNVs when there's no leakage to treat them?
If they're asymptomatic, they can be followed up about 3 to 4 monthly.
So what I meant is that if you have no leakage on OCT, but you have these networks that are shown on OCTA, yes, would you still treat them?
Ma'am, it is based as per the general consensus. If the patient is asymptomatic, whether the network is present or not, we don't treat it.
But if the patient is symptomatic,
if the patient is symptomatic, we may want to treat it.
No, we don't treat when there is no fluid.
No fluid, we cannot treat, but symptomatically we should.
See, the octa is used basically to decide. We are using octa in follow-up to decide the duration of follow-up. That is, if, depending on the changes in the octa, if there are only these large vessels, that is, that are present, then we can tell the patient you come after 3 months. The possibility of early recurrence is not there.
Sure.
But then when you find these smaller networks but no fluid, you know that possibly in the next 1-2 months he is likely to have a recurrence. So we call them a little early. So you use octa from that point of view. But just because octa is showing changes and fluid is not there, we are not treating at this moment of time.
Thank you.
And regarding the brolucizumab, it's a very interesting observation that you're telling. I think we'll have to look into our cases as to whether it causes. One thing what we have noticed is, in our experience, PED height definitely reduces significantly in patients with brolucizumab when compared to other
Yeah, they're absolutely right.
anti-VEGFs.
The reason why I asked the question was also because of their study where they showed that the PED collapses. Despite that, the vision did not improve in their set of patients for the AMD.
But that may be related to the PED also.
Yeah,
The
yeah,
PED collapse.
correct.
But in CSCR, usually we do not have that sort of a
PEDs.
collapse of the PED and
That's
changes.
right.
Yeah.
Thank you.
Actually,
Probably this big PED is what you are saying, ma'am. They might be having a degenerative or ischemic RPE at the top of PED, which is not letting vision improve even after they collapse.